Today on the podcast, we are honored to welcome the true pioneer in the breast health, Dr. Kenda Douaidari. She is the director of breast clinic at American Hospital, Dubai, and one of the leading breast interventional radiologists in the region. With over 15 years of international experience trained in the top teaching hospital in Paris, Dr. Douaidari has been at the forefront of innovation in the breast imaging and minimally invasive diagnostics. She was the first to introduce tomosynthesis guided vacuum assisted breast biopsies in the Middle East, and her expertise spans across advanced technique like 3D mammography, contrast enhanced mammography, breast ultrasound, and MRI. She is passionate advocate of personalized screening, especially for women at higher risk, and also been instrumental in setting up breast cancer early detection program in underserved communities. Dr. Kinda is not only respected clinician but also dedicated educator and public health leader. We are thrilled to have her join us to demystify breast health screening and what every woman needs to know. Welcome, Dr. Kinda. How are you?
Thank you. Thank you so much for the nice introduction.
Yeah.
Thanks for all the great job that you're doing. And thanks for having me here.
Yeah, you were so amazing. We met while I was your patient, and I asked some question and you answered me so well, and I was like, come on, welcome to my podcast. And of course, if you are a health educator and you have such amazing information, that should be out there for the people. And I'm really thankful that you accepted my invite. So let's talk about the breast health, because nowadays everybody's talking about it. So there are some questions, like I will be talking more like patient's language, because this special forum is for She's Well, and they are layman people. So I feel perfectly fine. Shall I need mammogram?
This is a very, very, very common question. And it's very important to know that doing mammograms is regarded, it has to be done regardless of any kind of symptoms. Because whenever we're talking about early detection, why do we do mammograms? We do it for early detection of breast cancer. So that means for finding cancers before they can be palpable. So in mammogram, we can find cancers 12 months at least before we can really feel them, because this is like we can find precancers, informal calcifications, distortions, small nodules that are not palpable, and this can make all the difference actually.
That's amazing. Actually, 12 months is quite an information. So, but still, it will be early cancer.
Yeah, exactly. So this is it. Early cancer means small cancers which didn't spread yet.
Yeah.
And again, this is the advantage. When we talk about screening, that means early detection. Early detection means finding these cancers. A cancer which has been found early, with like before being spread. The total, we say the survival rate is up to 98%.
Wow.
98%.
As if the cancer didn't happen.
Exactly. The same cancer, a year later, if it's spread, like we're talking a year later because it's a duplication time. So whenever we can find it, it's like if we say around 5-6 millimeter, a year later it will be double. So a year later, if it was spread, or 2 years later, let's say, if it was spread, the survival rate will be down to 27%.
Oh,
Imagine the difference.
That's 1/4.
Exactly. And this can make all the difference.
That's
survival
amazing.
rate, and then treatment options. Whenever the cancer is small, options of treatment are really minimal.
Conservative.
Surgery, radiation therapy is done. But then whenever it's spread, we have the chemo, we have all kind of, and then even the type of surgery, it goes from small cancer with small tumorectomy, like just they take the cancer, breast looks nice and well, or whenever it's large, we're for heading for the mastectomy and all kind of more aggressive treatments.
Right, amazing. So for us, like we have cervical cancer where it is preventable, but breast cancer, so to make it clear to the public that it's early detection, but early detection has amazing meaning. 98% 5-year survival is like really huge. So some of the people can still say that It's like if it has to happen, it will happen. It's a cancer. So let's talk about this.
Unfortunately, this is something like it's really sad because yes, it's fate. Yes, I agree. If it will happen, it will happen.
Right.
We cannot prevent breast cancer, but we can prevent dying from breast cancer. We can prevent. This is it. It's the mortality rate that we are lowering here. Now, all over the world, in like the developed countries, because screening is really well done and all, the percentage of breast cancer is getting higher because of many reasons, but then the mortality rate is getting lower because they are detecting it early. So this is the concentration. Okay, we don't prevent it, but we prevent dying from it, and this is something very, very important.
Yeah, exactly.
Yeah,
like and even the treatment, it won't be that of a hassle when it's advanced.
Exactly.
Yeah, exactly.
Yeah.
So now, like some of the women, they won't even go for, they may delay or avoid the screening just because of the fear and shame. What would you say to them?
I cannot forget one lady, a very, very nice lady. She was in her late 30s. She had this mass and she kept saying to herself, I'm young, it will be nothing. And then she had many things in her family around, a wedding of her sister, competition of her daughter, her husband, I don't know what. And she kept delaying like 14 months.
Oh
when she came, it was everywhere.
Oh my.
And it really makes you sad. You feel sad because you know that 1 year before she felt it, at least at that time, it could be, okay, maybe spread in the breast, maybe to the axilla, but not everywhere in her body. Whenever she came, it was too late. So she kept delaying it because of fear, because of she doesn't want to
Disturb
make anybody concerned about her. And then she lost it by the end. And this is so sad. So whenever we feel something, young ladies, they may have cysts, painful stuff. It's okay, it's benign, but then we will have to confirm it. We will have always to check, to go to our health practitioner, to our gynae, to our GP, and then they will ask you if you have, or if you need to go for mammogram, ultrasound, they will ask you to do so, but then you will have to face it. Whenever there is something, just please check it. Hopefully it will be nothing. But then whenever you know it's nothing, you're relieved. And if ever it was something, so you are protecting yourself from very, very, very unpleasant,
like she was so available to the family all those 14 months just to be totally non-available later on. So it's better, sad. Like they say, that we can live for our kids. So when you say we can live for our kids, go and screen for yourself. That's the most important thing. So the question where we started, remember I talked to you that mammogram is a radiation and you gave me a wonderful answer. So let's talk about that and let's inform our audience about that.
In fact, it's a misconception. Everybody, like a lot of ladies, they don't go for mammograms because of the radiation. They're afraid of radiation. I understand we all want to be healthy and to avoid things, but avoiding mammogram for radiation is really something, it has, I'm sorry to say it, but it's nonsense because, first of all, radiation of mammogram, the dose is really, really very low. There was this very interesting study in the US, like it was, I think, 2020, it was the corona time, and the study proved that the amount of radiation used in mammogram is equivalent to the amount of radiation in air and airports if you take an airplane from New York to LA. That means a 7-hour flight.
Yeah, exactly.
So if you go to Europe and come back, the amount of radiation is exactly the same as the mammogram. So it's really nothing. Yeah. It's not dangerous and it can never do any harm. The mammogram radiation, it's a soft tissue, So the amount is really, it's not like the CT scan and all. Still, these are investigations that we have to go. But a lot of ladies, they avoid, okay, I don't want to do mammogram every year, I don't know. But honestly, the advantages that we get from getting a mammogram is far, far, far much important from this potential unreal risk of radiation.
Yeah, amazing. Yeah. So cosmic radiation in 7 hours flight is much more than the mammogram, or at least equivalent.
Exactly.
And we never consider that as radiation.
Yeah, exactly.
That's the thing, So can mammogram miss a cancer, or how accurate it is?
Yeah, it can. Yes, it can.
Yeah.
Mammogram is very accurate in detecting cancers and early signs of cancers.
Right.
But sometimes, whenever the breast is very dense,
Yeah.
dense breast, that means the mammogram comes white.
Yeah.
So we can miss cancers then.
Right.
But then we combine. This is why we combine modalities. There is no perfect modality that has a very high sensitivity and very high specificity.
Yeah.
It's just, this is why we combine. This is why we add ultrasound.
Right.
If it's a dense breast, always we add ultrasound. Sometimes we may need a MRI. Sometimes we do the contrast enhanced mammogram. So it's the multimodality concept that we are always using to have the best outcome.
Right. Amazing. So above 40, they're mostly dense breasts, so they have to combine. What about the younger than 40 years?
So normally dense breast, actually we have 4 types of breast density, and we are born with this density. So like there are ladies with fat breasts, there are ladies with mixed with more fat, with mixed with more gland and very glandular, which is the dense breast. So regardless of the age actually. And normally dense breasts we combine with ultrasound. So starting 40 we do mammograms, and if it's a dense breast, if it's 3 or 4 density, type 3 or 4, we do ultrasounds always.
Right.
For young ladies under 40, if they don't have risk factors, we just do ultrasound. Unless there are risk factors.
Yeah. So what's the difference between diagnostic and screening mammogram?
So when we say screening mammogram, it's for ladies who don't feel anything, no symptoms, nothing at all. They're coming every year for screening mammogram. It's a screening. We all know everything is about preventive medicine, So preventive medicine, we do our pap smears, we do our colonoscopies after a certain age, and we do these screening mammograms without feeling anything, just in order, if anything is starting to change, so we can detect it the earliest possible.
Yeah.
Diagnostic, whenever we have symptoms.
Right.
If I feel a mass, lump, change in the skin, change in the nipple, discharge, all kinds of symptoms, then we call it a diagnostic mammogram, because we have something that we are checking,
So that is with some presentation, like patient is feeling something.
Yeah, exactly.
Now let's talk about 2D or 3D mammogram.
2D or 3D. 3D is the better mammogram.
Yeah.
3D, or we call it tomosynthesis actually. Tomosynthesis mammogram or 3D mammogram, it's, from your point of view as a patient, it's the same. It's a mammogram.
Yeah.
But it's a different software with the new machines that gives slices of 1 millimeter, like the breast. For example, we're having 60 to 71 millimeter slice, so we can go through. Whenever we see it, we can go through also. It's far much more sensitive.
Right.
It can detect earlier cancers, smaller cancers. And as well, sometimes with mammogram, the 2D, we have the whole density of the breast in one projection.
Right.
The 3D, we're scrolling through the breast.
Yeah.
So we're seeing even sometimes there are a kind of superimposition of gland that we think, it may be something. In tomo, we realize, no, it's nothing. So it's very helpful. And normally, if it's available, just always go for 3D mammogram, because it's far more sensitive.
So tomosynthesis is 3D?
Yes.
Okay. And it has more slices or enlarged view?
Yeah, exactly.
It's enlarged view. Amazing. And I think you guys are the pioneer in American hospital to have the tomosynthesis. So nowadays in the LinkedIn, I was just reading that now AI has been introduced, and that can tell much, much earlier about the normal or the risk of breast cancer.
In fact, AI has a great potential actually.
Yeah.
It can help like a second reader, as a second reader to increase the sensitivity of the mammogram reading.
Right.
And it can help a lot whenever we don't have always dedicated like breast radiologists. Like in many places we have a kind of a general radiologist who is really very good, but he's reading mammograms. So AI helps a lot in detecting earlier cancers whenever we are not really well prepared to read mammograms. even for us, it's a kind of a second pair of eyes, which can help us sometimes, like, with calcifications, with distortions. So it's really helpful, and it has a great potential. So,
Wow.
yeah.
So far, still it's not established. And also, it's understandable that it will remove the subjectiveness. And also, but it cannot be without supervision of a human eye.
Exactly.
I don't think so. Like, it would be on its own.
And this is why we always say, like, AI will not replace radiologists, but it will replace radiologists who doesn't use AI, So
Yeah, exactly. Yeah, that's very smart.
It's really true, because AI can help us in many things, It helps us in many tasks, repetitive tasks. For example, in triaging cases. So if you have a lot of mammograms, at least it can triage the most important ones, so you deal with them, on the spot.
Yes, exactly.
You give priority to these cases whenever there are large screening programs. This is amazing, because at least the others, like the BIRADS 1 or 2, the normal ones, you can leave them like few days to, So it has a lot of, exactly.
But still, it's not established.
It's not well established.
It's promising.
It's very promising. Yeah, it is.
Maybe the future.
Yeah.
Along with the radiologist, like Dr. Kinda, of course. So, nowadays, I think no talk can be complete without talking about AI.
Yeah.
So just last hour, I was talking about AI. So some cancers can only be detected on ultrasound. So why not just ultrasound? Why mammogram?
Yeah, this is as well a very, very common, question. Mammogram is the main diagnostic modality for breast cancer, because, as I said before, it can detect things that we can never see in ultrasound, like calcifications, distortion. This is not an ultrasound finding. This is only mammogram. But then ultrasound can find nodules. Ultrasound is very good in nodules. So whenever the breast is very dense, and this is where mammogram cannot find the cancer, and then ultrasound can find it. If the breast is dense, the areas of density, it's white on mammogram. So this is why small nodules can be missed, and here comes the role of the ultrasound. But it's to complete the mammogram, because again, there are things that are not seen in ultrasound, only in mammogram. So this is why this is the multimodality
They both have
approach.
values.
Exactly.
They're not replaceable.
We combine modalities.
Yes, amazing. So, like, who are the people who need MRI? And is it more accurate than mammogram? If it is, why not MRI?
Yeah, MRI is mammogram and ultrasound, this is a morphological, like we see and we check, and it's the morphology. MRI, we inject contrast material, so it's the blood concentration that we are looking for. So it's a functional imaging. Okay. So combining both can give a kind of a very important, very important information. The thing that MRI is very good. It's very sensitive, but it's too sensitive. So it has a lot of false positives. Because, many times we have a lot of enhancements everywhere, and it's just the breast tissue enhancement, the background enhancement, or like benign enhancement. Sometimes we have to go for biopsies for nothing. But still, it's very important in certain cases. This is why we don't use it as for every lady, like a kind of screening, because then we'll be doing endless biopsies. But then it can be used for a certain type of ladies. For example, whenever we are higher risk category with a lot of family history, before, like if a patient has breast cancer before surgery, it has certain indications. And with dense breast as well, sometimes we go for the MRI to confirm that there is nothing. So it has its own indications. It's a very important exam, but it's not like for usual screening for usual ladies. Now we have the contrast-enhanced mammogram as well. Yeah. The contrast-enhanced mammogram is a mammogram, but we inject iodine material. So we have both information, the morphology and the function. It gives information similar to the MRI. MRI is still more sensitive, but this has... it gives us important information that can, that this is why sometimes when we cannot do the MRI, we do the contrast. Whenever we have dense breast, sometimes we do contrast, so we are fine. We know that we had all the information that we want. Amazing.
So, like you said, contrast enhanced mammogram also. So if you're doing the first step, the morpho by ultrasound and mammogram, So then if contrast enhanced mammogram is available and MRI is available, so which one you will go for?
So the thing that now the contrast enhanced mammogram, it has been there like for 10 years. Now it's taking its place. Till now, what we do, whenever we have really a high-risk lady, we go for the MRI. But then intermediate risk lady, like for example...
Is it the MRI could be first line in some people?
Yeah, the MRI first line in like ladies who have BRCA positive, for example.
Okay, very high
genetically
risk.
positive. Yeah, very high risk. So we don't want to miss the chance of detecting whatever is there. So we do MRIs, you know.
Directly.
But then,
or
we do
don't
MRIs. We
complement.
alternate. Actually, it's a personalized screening now. And this is why, like, for what we do, actually, we have an assessment, a risk assessment for each lady. So we define these ladies depending on their risks. And whenever we know that the lady is in a higher risk category, we alternate. We do mammogram every year and MRI every year with 6-month interval. This is the protocol.
Amazing.
It's the American Society protocol, and the Europeans as well, they're following this. And then you ask about the contrast enhanced mammogram. For example, when I have a lady with dense breast, but she doesn't have any risk factors or whatever. So I would tell her next year, let's do the contrast enhanced mammogram. So we have both information.
Amazing.
And then we will just alternate doing mammogram a year, contrast mammogram next year. And it's always a personalized screening.
So that's a high risk people.
Exactly.
But still they don't have any findings.
Yeah, of course, of course. So
and MRI is more with the people who have some findings.
Actually, MRI is like the indications of MRI. First of all, for ladies, the high-risk ladies, as I told you, even if they don't have any findings, we do it because we want the highest. Because normally, for example, BRCA positive ladies, they have very benign. Sometimes it can be like very good-looking tumor that can be missed. So this is why we add MRIs always. When a lady is diagnosed with breast cancer, before surgery, we do the MRI just to be sure there is nothing else around and all. It's exactly for staging. This is very important. Sometimes when the lady is a higher risk category with family history, so we do MRI. So these are the indications.
Even as a secondary investigation, when you don't have information complete through the ultrasound and mammogram.
Sometimes it's a problem solving.
Solving.
Like we have
a next step.
Exactly. Sometimes we have ladies feeling a mass. We do mammogram ultrasound, we find nothing. Still, she's feeling something. So we need a third modality confirmation.
Exactly.
We go for the MRI or the contrast enhanced mammogram.
And it's always just better to do the error on the side of safety when you're questioning. Amazing. So some countries, they're doing mammogram 2 to 3 yearly. We are doing it yearly. So why?
So I will tell you why.
This
is very interesting because normally the scientific societies, they all agree that doing mammogram every year is the best practice. It's the best thing to be done. There is a lot of confusion. Here in Dubai, we have people coming from everywhere in the world. And everyone has his own country recommendations. And then we are all confused. We have doctors from everywhere. And the recommendations, like, it's really
all
confusing.
Over the place,
So, for example, in the UK, they do it every 3 years. But why do they do it every 3 years? Because these are national programs. National programs,
budgeting.
That means government pay for it.
Exactly.
And they have to afford doing it in like similarly for every lady that they have. And they cannot afford it, that's budget-wise. So they all agree in the UK even, they all agree that 3 years is too much. And they have the highest actually interval cancer in Europe, you know. The mortality rate with interval cancer is very high. Because of the 3 years. But for them, this is budget-wise, they cannot afford doing it more. And this is why private insurances in UK, they offer it every year. But the NHS, it's like in France, for example.
More of the money matter rather than a recommendation.
And it's just a budget-wise because they cannot, like in France, it's every 2 years. And it's the same because 2 years, they cannot afford doing it more than 2 years. So 2 years is fair for them, which is at least better than the 3 years. The American Cancer Society, it's every year, like in Sweden and all, because they have a higher level of health system, so they do it every year. The scientific societies and the researchers and studies, they all agree on the importance of doing it every year, actually.
Amazing. So at what age, my audience, mostly young people, so they are just waiting for your recommendation at what age they should start having this screen.
You have a nice logo, by the way. I like it.
I'll explain to you about this. She might not be very well. Her eyes are down, but her neck is up because, she wants to be all right. She has a messy bun, but flower is there to show the world that I'm all right.
Yeah. Which is good. It's all about positivity in this
Exactly.
life.
And women is master of that.
Yeah, of course.
Yeah.
So about the age, we said 40 is the cutoff age. So starting 40, you have to start mammograms. And
along with the scan.
Yes, along
yearly.
with the scan, whenever she has dense breast, it has to be ultrasound.
Probably above 40.
Yeah.
It's very common dense breast. Yeah.
Exactly, it is. Then whenever we're under 40, ultrasound is enough. Unless if the lady has a family history or risk factors, like sometimes why the risk is increasing with some ladies. Sometimes a lot of IVF, rounds. She had a lot of hormones, so she has to start earlier. If she had, for example, a kind of radiation whenever she's young for any kind of illness, she has to start earlier. If she has
so when we say earlier, is it 30?
So normally, like for example, for the family history, we start 10 years before the youngest family history. So if she has a mother, for example, 40 years old when she got the cancer,
30.
We start 30. So 30, we don't start annual mammograms. It will be too much. The breast is very dense at all. We start MRIs. We alternate 1 year mammogram, 1 year MRI. So it's all personalized screening depending on the case itself,
That's amazing. So if somebody has BRCA, it has to be started earlier.
Yeah, BRCA, we start really early.
How?
We start because BRCA positive, that means she has over 50% of having breast cancer in her lifetime.
So 25?
So normally, yes, we start 25 as a baseline MRI. And then depending on the MRI, we do ultrasounds and MRIs. Till she's 30, we start a baseline mammogram. And then we alternate. Whenever she's 40, we have always 35 actually and above. We alternate mammogram every year and MRI every year with 6-month intervals. So she's covered every 6 months with a different type of modality.
Yeah. That's amazing. You said baseline. This thing I started my breast screening much later, and I heard from my radiologist that we do not have your baseline.
Yeah.
So that is also very important. So is it ideal to get it done in the same place because they have the baseline and they can see the difference in the images?
Yeah, it's better always to do it in the same place. Or
at least to keep the CD.
Exactly, because it's very important to compare, to compare images just to see if there are any changes. Sometimes we have asymmetrical densities. It's only the gland. So if we know about it before, we avoid doing follow-ups for these. Sometimes we have calcifications, old ones, benign ones. They were always there, but if we don't know about it, then we have to go every 6 months. If we have the baseline, we go back and then we compare and we are fine. It's better,
Amazing. Also, if somebody has BI-RADS 3, normally what I know, to be BI-RADS 2, it is 6 monthly for 2 years, and they can be classified, and that is the value of the baseline. That if baseline was there, they could compare, and they can actually classify it under BI-RADS 2.
Exactly. We skip the follow-ups if we have a baseline one, if we have previous exams to compare. This is why whenever we go for mammograms and ultrasound, it's very important to have the old ones. If we're not going to the same place, it's very important to bring with us our old exams to avoid this, to avoid, first of all, additional imaging, and to avoid these follow-ups every 6 months for 2 years. So if it's there, if it was, I have a previous one 2 years ago, it's the same, I put it by RADS 2 right away, and we're fine, we're done with that,
And it decreases stress a lot because,
of course,
with BI-RADS 3, my gosh, the question.
What if?
What if? Also, and sometimes the young people getting that label that BI-RADS 3, they become real anxious that something happening.
True.
So you talked about personalized screening. I like that thing. So what's difference between the standard mammogram and the personalized screening?
So personalized screening actually is a very important concept. And always, whenever we have each lady comes, we just do this assessment to know where she is in the risk category.
Right.
So we can provide personalized screening. So we said For each lady starting 40, we have to go for mammograms and ultrasounds every year. This is the norm. But then if she's in a higher risk category, so how do we do this assessment? We ask questions, many questions.
Right.
And then there is a software that gives a kind of estimation, and we know where she is in her risk.
Amazing.
So what we do, whenever she is 20% and above, then she is in a higher risk category.
Right.
So under 20%, she's just the normal, like mammograms, ultrasounds, whatever. This is every year, that's it. If she's higher than that, then we offer a plan for organized or personalized screening. So we add MRIs, or we add follow-ups, or we add the 6-month interval exams. And it's always an informed decision. So we sit with a lady and we discuss it and we tell her how high is her risk. So normally if it's like 21, 25, whatever, she has the choice, to go for this, MRI. We're not very strict with it because the risk is lower. But then whenever she's 30, 40, and then we say, no, listen, it's like we are here, we have to take it seriously. It has to be an informed decision. The lady, she has to know where she is. And then she decide if she wants to. Some ladies, they said, it's too much stress. I will go with the annual. But you have to know, and you have to have an informed decision. Right. And this is very important.
Yeah, at the end of the day, it's customer-led healthcare services, but they have to have the information.
Yeah.
So this thing, the personalized screening by risk assessment. So risk assessment is a questionnaire or it's some test?
It's a questionnaire, actually.
Yeah.
Each lady comes to us, for example, if she has, now our technicians, they know exactly what to do. Whenever there is any kind of possibility of high risk, they run the test, the risk estimation.
Right.
Like if you come and you have nothing,
Yeah.
you have kids, you never had a family history of breast cancer, you never had any radiation whenever you were young, they don't run it because this risk is very low. We know.
Right.
Then, whenever there is a family history, whenever there is an IVF treatment, whenever there is any kind of risk factors, then they run the assessment test. The assessment test have questions about your weight, starting with your weight. And then if you have family history, if you have hormones, if you have any hormonal treatment, if you have kids, and what was the age of your first period, what was the age of your first kid, all
These
this
information.
detail. It's very, very detailed.
Yeah.
And then combining with the density of the breast.
Yeah.
So the risk increases with the density of the breast. And
so
then
data also goes.
Yeah, exactly.
Yeah.
So all together, then it's a software. It calculates the risk. It gives us the risk, and we know where we are.
What that scoring is called?
It's IBIS.
Right.
It's the thyroid Kazakh. There are different models in the world. There is the Gale model. The thyroid Kazakh is the best one because it includes the density of the breast. And it includes, with the family history, it includes the father side. So it's really good. So we do it to each lady that can be in a higher risk category.
And then counseling also goes along with that.
And then whenever we have a higher risk, then we offer the possibilities and the personalized screening options that we suggest, all this is depending on statistics and studies and recommendations. So there are guidelines and there are recommendations, you know. So the guidelines, it's strict 1, 2, 3, but then again, the recommendations, whenever we're in the higher risk category, exactly, we consider this. If you're intermediate risk with this, so it's a whole, it's our radiologists, they're really trained to go through all this with the ladies, and we are always, we're insisting always in going through all the details whenever we have a higher risk category, because we know that there is a higher possibility and we don't want to miss it.
Yeah, that's amazing to know, because, now fields have separated.
Yeah.
So gynae world, a lot might be happening, breast. So every field, even the subspecialty is separating. So there's a lot already there.
This is why it's important always, whenever we do our mammograms and ultrasounds, to choose a breast dedicated breast radiologist, not like a general person. They are very good and excellent, but then it's a kind of a dedicated.
So vast it has become, actually.
Exactly.
It's not the same which it used to be in the past. So let's talk about dense breast, because a a lot of women, they want to understand what does it mean. Normally, I explain to them that a tissue paper, when it's filled with the air a bit, it's
True.
not dense, and when you just compact it,
dense.
it's a dense. So what are the
In fact,
implications of that?
So the breast, as I said, there are 4 densities of the breast. The breast is fat and gland and
Yeah.
connective tissue. So we
Right.
have the gland where the
Right.
milk comes from whenever we're breastfeeding, and we have the fat. Some ladies, they have all fatty breasts, like fatty, transparent. For us, this is the best to have because it's easy, transparent. You can never miss anything.
Right.
For the lady itself,
That
this
is
is
young
the soft
ladies.
breast. No, actually, you can be. It's density of the breast has nothing to do with the age.
Right.
It's you're born with this density of the
Right.
breast. Actually,
It's not due to obesity or being slim.
No, whenever we're like obesity, that means there is extra fat.
Yeah.
So then, yes, it becomes
It
more
could be.
fatty. The gland becomes smaller because the gland is there, and then a lot
Scattered.
of fat is there. You
Yeah.
know, but then normally we can have young ladies with
Yeah.
totally fatty breasts.
Yeah.
Slim ladies, or we can have like older ladies with dense breasts. Normally, with age, after menopause, the density is getting lower, you know.
Ah, okay.
But then these 4 densities, we have completely fat. This is, the transparent one, and we have completely glandular one. No
Yeah.
fat. It's all. It comes white, and this
4.
is this is 4. 4. That means it's all gland. So sometimes it's really, really very tricky.
Yeah.
And as I told you, even in the risk assessment, whenever we put 4, the risk increases.
Yeah.
And there is always this question: if I have a dense breast, I'm in a higher risk, at a higher risk of getting breast cancer. There are studies and research suggesting this, but the thing that it's not. Because it's a proliferative gland,
Yeah.
but that doesn't mean that fatty breasts don't get breast cancer, and the gland, the dense ones, can get. But it's harder to find cancers. It's more proliferative, so it can have a lot of fibrosis, adenosis. It can be more affected with any hormonal,
Yeah.
excessive hormones and all.
Yeah.
So this is how it is.
So hormones can also increase the density of the breast.
Yeah, it increases actually. The hormone can affect the breast density, and it can affect the cellularity of the breast. So it's like congestions come because of hormones.
Yeah.
Sometimes some cells can get into hyperplastic, like it can have hyperplasia. This is how it affects. Some breasts are not affected by hormones at all, but then we don't know which is which and who will be and who will not.
Right. So now microcalcifications, mammogram has a lot of such reports. So why we focus on microcalcifications? Let's
We
explain.
focus a lot of microcalcifications because it's the early detection of DCIS, which is the cancer, the pre-cancer stuff, is all about calcifications actually. Calcifications in the breast can be totally benign.
Yeah.
So the thing that, when we say calcifications, that doesn't mean it's bad. Sometimes we have totally benign calcifications. We can label them as benign from how they look. Sometimes we have very suspicious calcifications, and calcifications, they are inside the ducts. It's the necrosis inside the duct. So whenever there is a necrosis in a different way, we have this kind of ugly calcifications,
Right.
and we can label them very suspicious.
Yeah.
A lot of the times we have indeterminate ones. They look fine, but it's distribution. They look linear. So these are the ones that we don't know if it will be something or not. And then we
Linears
order
are
biopsy.
not okay.
Actually, it's the form of the calcifications and the distribution. The form, how do they look? If they look, if they look branching, and this is very suspicious. But then if they look like round, like points, like dots, these are fine.
Right.
But then there is the distribution. If they look linear, that means that this is a duct. So this is a question mark. Why do. But then if they look like just round and there, that means it's just a lobule with calcified cysts. Sometimes we have cysts. Sometimes we have calcifications in cystic wall. It's totally benign. So different types of calcifications. And this is why some calcifications we follow up because they look fine, but we need to keep an eye on them.
Exactly.
Some we forget about them from the beginning. And some we go directly for the biopsy, like we don't even wait. So this is...
and tomosynthesis also can help with those calcification.
Yes, of course. And tomosynthesis, it can help with other kind of distortion, which is the distortion sometimes there is a kind of changes in the cells. Like the parenchyma of the breast is distorted, but it didn't form a mass yet. We're in the early stage where it's distorted, but it's not a mass. The same thing, if we leave it in 6 months or a year, it will give a mass.
Yeah.
So when we see it, and tomo is excellent in this, actually. This is a very big advantage of tomo. So we can detect earlier cancers because of this distortion, because before it becomes a nodule, which has a big advantage.
Right, amazing. When we were children, we used to hear that don't let them do the biopsy.
Yeah.
Now, as a doctor, I know biopsy is just taking the tissue and sending it to histopathologists, and they see it under microscope. Same goes for the breast. They keep saying that don't let them do the biopsy because it will spread.
You said that when we were young.
Yeah.
Actually, from where it's a misconception.
Yeah,
biopsy
exactly.
is totally safe. But it came before these new techniques in getting the biopsies of the breast, needle biopsy, or now the biopsy. How do we do it? It's a needle. It's closed. It's an automatic needle, and it's actually 2 needles on top of each other. So whenever we click, it goes. It takes it goes closed inside. We click, it opens, takes the fragment, closes back. Whenever I pull it back, it's closed and the fragment is inside. So this is the technique of the biopsy.
Advanced.
Before, this new technique of biopsy, breast biopsy, was not available. So they used to open, they do surgical biopsy.
Exactly.
They used to open, take tissue and close back. And this is very dangerous. This will spread the tumor everywhere.
Exactly.
Because you open, you take tissue, you close it back, and then this is all around everywhere.
Yeah.
And this spreads the tumor.
You let the breadcrumbs. Yeah?
Exactly. And this is why people till now say don't do biopsy because it will spread it out. But now this is not a surgical biopsy anymore. It's the new technique, which is very advanced and which is very safe.
And it looks really nice.
And it has been there actually now. It has been there for, I can say, 40 years. And it's just very safe we never had any cases of spread tumor cells because of biopsy.
Yeah. So pre-cancer disease. Let's talk about it. If you say somebody that you have a pre-cancer disease, so what does that mean?
So pre-cancer, that means small cancer which is inside the cell, but it didn't go out. And this is where we were talking about calcifications. Calcifications, sometimes we do calcification, we do biopsy, and then it turns out to be an in situ, we call it, tumor in situ. What
With
does
the
that
limiting
mean?
membrane
Exactly.
not
exactly.
broke.
It's inside the membrane of the cell. It didn't go out yet.
Yeah.
It's a pre-cancer, but it's going, it's working, it's going. Most probably it will form a cancer in the future. Yeah. And when we find it, actually, honestly, when I inform a lady that she has a pre-cancer, I tell her you have to feel lucky.
Yeah.
Because finding it at this stage, it saved her life because it's still a pre-cancer. It's a small, tiny surgery, no treatments needed, nothing. And then it's gone.
Yeah.
The same thing in 6 months or 1 year, it would be a real cancer, and then we will go into a different stage.
Yeah.
So pre-cancer is really, really stage 0, we say, actually, of cancer.
So it means disease is gone. You may need surveillance, but disease is gone.
Yeah.
That's amazing. So somebody said they don't have family history. Still, they have to do the screening?
Yes, of course.
Yeah, of course.
Actually, hereditary
Nowadays,
breast cancer, genetic breast cancer is only 20% of breast cancer.
Right. Still
80% of breast cancer is not genetic. So we have a lot of ladies having cancer without having any family history.
If somebody has a benign lump, are they more at risk of getting cancer?
No, benign lumps like fibroadenomas or fibrosis or all this is totally benign and fine, nothing to worry about. Sometimes we have high-risk lesions. High-risk lesions, they are benign, but high risk. There are certain, pathologies.
Histopathology.
Yeah, exactly. Like the papilloma is a higher risk. The radial scar is a higher risk. These are a higher, there is a category.
What about
phyllodes tumor, this is a benign one, but it's a high risk. So it has to be taken and they have to have safe margins all around because it can come back. And phyllodes tumor, it can be benign, it can be intermediate, it can be malignant.
Okay. So it
And
depends on histopathology.
Exactly. This is why it's very, very important to take it out. Even if it's a benign phyllodes, it has to be out. And it multiplies. It increases in size significantly.
Right. So lifestyle modifications like exercise, diet, and weight management, do they affect?
Of course, healthy lifestyle, it boosts our immunity system, and it prevents all kind of cancers. It's just important.
People with the breast implant, does it affect the screening?
It makes our job harder.
Yeah.
First of all, like implants, they don't cause cancer. There is a slight amount of, it's a very, very rare incident that happened with a certain type of implant, like anaplastic lymphoma, as we say. This is something that these implants were recalled and all. But implants in general, they don't cause cancer. But it makes it harder to detect cancer, yes, because in mammogram, we can see 80% of the breast only.
Yeah.
So we do always ultrasound. Sometimes we do MRI, sometimes. So it makes it harder to find the cancer in certain places of the breast, where it's covered with the implant.
But still, it's possible, and they should.
Of course,
they should do it also. So, what happens if somebody's called back for mammogram report? Should they panic?
No, sometimes what we do, like what I do in my practice, it's a real-time, like a mammogram and ultrasound, like a real-time on one step. That means I'm there. I'm checking the mammogram. I'm checking the ultrasound. I'm doing the ultrasound. So the patient will not be called back because she will have her final answer. In the same time, she goes out with her final answer. But in a lot of places and in a lot of screening programs, the lady goes and she has her mammogram, and then they will call her back and, like just a mammogram, and then the radiologist will read it later.
Yeah, so it is just a setup.
Exactly. So then if the radiologist sees something like, calcification that needs magnification or some compression or additional imaging, they call her back to come for additional imaging. So she has to take it seriously. She has to come back for this imaging.
Right.
But that doesn't mean that she has something.
Even with the normal report, you need to know the plan next.
Yeah.
When to do, what to do.
Yeah.
So it's better to come to the hospital, have more discussion than not.
True.
Now, recently, I have one patient, she's pregnant and she has to have some hormonal support, and she was so scared that she has a lump. So hormones and the breast masses, that's very topic around,
So actually always we have, before getting any kind of hormones, we'll have to check. We'll have to do, depending on the age, if she's very young, we do ultrasound. If she's like... before getting hormones, we have to have a clear idea about the breast, if there is anything there. Yes, hormones sometimes, even fibroadenomas, they can boost it. Like with hormones, it can get larger. If there is any potential cancer, it may get large. But then if there is nothing at all and hormone is a necessity, then they go for hormones, and then we just continue doing follow-up, doing whatever we have to do.
So ideally, it should be histopathology should be done to evaluate what is the mass. But even if it is not done, at least they can do the serial scans to see what is the effect of the hormones.
True.
So there's nothing. Then one last question, and it's not the least. Men can have the cancer too.
Unfortunately.
And what are the signs?
They can. So 1% of breast cancer is like happening in men. And the symptoms, normally it's a lump. Actually, with men. Rarely it's a discharge or whatever, because they don't have ducts normally. But then it's a lump. They feel a lump, hard one, unusual. And then they come. A lot of now, like there are a lot of, sometimes it's only a gynecomastia. It's just a kind of asymmetrical breast, whatever. It's just gynecomastia. But they have to check. Whenever they feel something, they go to the breast surgeon, and then breast surgeon will decide to send them for mammogram. Sometimes we do mammograms. We have to do mammograms just to check it. If it's a lump, we do biopsies. And the gene is very important. When the man has a family history, like his mother or his sister or his daughter or whatever, then if there is a gene history in the family, he can have the gene. And if he has the gene, he can get the breast cancer.
Right.
So it's important just to be aware.
Yeah, exactly. And they should report if any symptoms is there. Dr. Kinda, right now, all the women, they're listening to you, and even the brothers, fathers, mothers, husbands, everyone. So do you want to give some message directly to the audience?
So I would like to say, don't be afraid of breast cancer. Breast cancer is a disease. It's as every other disease. It can be completely treated in case it was found early. So early detection is the key. Please go for your annual checks. Don't be afraid of radiation or anything else. It can save your life.
So, Dr. Kinda, you brought so much information. All the women, they would have been informed about the breast screening, which is very, very important. So, we have a tradition that anybody who comes and brings so much information to our audience, to the She's Well, they get this souvenir from us.
Thank you
so
so
there's
much.
a thanks there, and there's a QR code which can be scanned to see our podcast.
Thank you so much.
yeah.
Thank you so much. Really, it's a great initiative with all these informative sessions and podcasts that you're having. You're helping a lot. Thank you so much.
And it is because the people like you ready to come and share their information.
Thank you.